So if you go to the ER with some sort of pain, it doesn't matter where that pain is, those practitioners are all going to try to figure out what is the source of that pain. That pain could be a whole host of different things. It could be cancer, right? It could be a nerve that's impinged. It could be a blood clot. It could be any number of things that is causing that pain. And it's very important to determine what is that painful thing.
You're listening to Cold Press Conversations with Dr. Jewel White Williams, a lover of numbers, lists, and a good glass of cold press juice, who is sharing episodes each week to help you explore the back end of healthcare and health sciences. Where a lot of that grit is done, we'll dive into topics covering research, education, and clinical practices, as well as guest shows with other leaders in the field. Pull up a seat and let's dive into these amazing and game-changing conversations. Hello and welcome to Cold Press Conversations. I am Dr. Jewel. I am a former educator. I am currently an EMS practitioner, and I also love speaking to people who are in the medical and health sciences field. Today, I currently have Mr. David Jetter, a passionate advocate for pain resolution and efficient movement, serves as a beacon of expertise in the field of physical therapy in Spokane, Washington. With a steadfast commitment to providing personalized care, David specializes in orthopedics with a profound emphasis in manual therapy. His journey towards becoming a distinguished physical therapist began in 1995 when he relocated to Spokane to pursue a degree in biology at Eastern Washington University. Earning acceptance into EWU's esteemed physical therapy program marked the inception of his remarkable career. In 2001, David Jetter graduated equipped with a master's in physical therapy, laying the foundation for his professional endeavors. As a practitioner at an outpatient orthopedic care facility in Spokane, his practice embodies a patient-centric philosophy with an unwavering dedication to understanding each patient's unique narrative. He and his team craft individualized treatment plans that serve as roadmaps to pain resolution and enhanced functionality. He enjoys mountain biking. He enjoys racing, fly fishing, golfing, all outdoor activities because of the beautiful Northwest. And he enjoys being with his family. Welcome.
Thanks so much for having me.
I'm excited. This is going to be a really fun interview. I was looking up about physical therapy, and there was this one particular place that stated, come in and get evaluated to know exactly what your level of physical health is from a therapist. And we will give you a plan for the year. You don't have to come to us, but our intention is to make sure that you are treating your body well. I thought it was very interesting.
There's definitely a movement in the physical therapy realm where there's almost like a primary care physical therapist.
There we go. I like the way you worded it. That's exactly what it was like.
It's frustrating for me a lot of times because people come in. I had this young lady come in and she was talking about how she had low back pain since November. This low back pain just kept getting worse and kept getting worse and kept getting worse. And now she's at the point where her whole leg is numb and pain down her leg. And she's starting to talk about a little bit of bowel and bladder control problems, which makes me start to think like, that sounds more ER-ish than physical therapy-ish. But, let's kind of continue down the path. But if she had seen me long ago, maybe even before her back pain had started, we might have been able to identify a movement dysfunction and a lack of ability for her to move properly that was contributing to her low back pain. And I think the idea that we should wait until we have this massive pain problem is antithetical to what musculoskeletal health should be, which is, can you move through normal range of motion? Can you be strong through that normal range of motion? Can you balance? Do you have good coordination? All of these aspects are things that we can and should be working on a daily basis.
Good. I like that. I wanted to just start it off with what I had read. And I thought it was really interesting because, everyone's talking about whole health. We're talking about making sure we have our mind right, our body right, make sure we're eating properly. And the way we treat our body collectively is going to allow us to be a better person. And we can serve our families better and we can serve those who we work with better. And I thought it was pretty interesting.
So I love the way that you worded it, the PCP of physical therapy. But what would you consider as a misconception or misunderstanding about physical therapy and pain resolution there?
Well, I think the biggest thing that I fight is this idea that the painful tissue is the most important thing. I'll give you an example of knee pain, right?
Okay.
If someone comes in and has a painful knee, a lot of times they have a meniscus that's irritated, right? That little cartilaginous structure in your knee that's irritated. Now, when you really dig into the history of the person, they don't have a huge mechanism of injury. They aren't a football player that got tackled sideways or whatever. They just kind of stepped off a curb and they kind of felt this tweak, and now my knee's swollen and irritated. Okay, well, that doesn't sound like a real mechanism of injury here. So then we start thinking about the problem of, okay, well, what do knees do? They straighten and they bend. That's what they do. They don't do rotation, really, right? In a standing position, your knee really doesn't have a ton of rotation. But if you stand on both legs and then you turn and look behind you, your hips and pelvis should be doing a lot of rotation. Your thoracic spine should be doing a lot of rotation. Your ankles should be doing a lot of rotation. So that knee is between two joints, two regions that do a lot of rotation. So it's sandwiched between two rotatory centers and the knee doesn't rotate. So guess what? If the hip isn't doing its job, then the rotational stress goes into the knee. Guess what the meniscus doesn't like? A rotational stress. Right. So the person comes in with a knee problem ostensibly, but really what they have is a lack of hip mobility and dynamic stability in both the rotational and side to side planes. And that stress is getting related to the knee and creating meniscus irritation. So you could go in there and you could shoot some cortisone to make it calm down, or you could go in there and do an arthroscopic surgery to trim out that irritated piece of meniscus. But if you haven't really looked at what the actual problem is, which is a movement dysfunction and a dynamic stability problem, that's bound to come back, which is why people have five, knee scopes and then before they have their total knee.
Oh, wow. Oh, I'm glad we brought that up then. I like your example. I was just thinking of somebody I know who has knee issues, but they're finally going for physical therapy.
Well, I think the other piece of the problem too is the whole healthcare system is focused on that painful tissue for good reason, right? So if you go to the ER with some sort of pain, it doesn't matter where that pain is, those practitioners are all going to try to figure out what is the source of that pain. That pain could be a whole host of different things. It could be cancer, right? It could be a nerve that's impinged. It could be a blood clot. It could be any number of things that is causing that pain. And it's very important to determine what is that painful thing? What is the painful structure? But once you've identified that that painful structure is a tendon or a ligament or a muscle or a joint or something like that, then the conversation needs to shift from what is the painful structure to why is that structure painful? And that's the problem is when we focus too much on what structure is painful, we start looking at that structure as the problem as opposed to the result of the problem. We start looking at that structure that's painful, not as the victim, but as the culprit. But really the culprit is something else that's not doing its job, that's putting more stress on that painful tissue. So as physical therapists, we get this referral that says meniscus irritation, knee pain, and we have to look at that and say, okay, yes, I agree that the meniscus is the source of the pain. But now we have to ask the question, why is that meniscus irritated? And then we have to delve into what is the leg doing? What is the rest of the leg doing that is causing more stress on this meniscus? And a lot of times people are coming into my office, insurance companies are requiring 6 visits of physical therapy before they'll authorize an MRI. And physicians get really irritated with that process because insurance companies are dictating care and whatnot. I don't disagree that insurance companies should not be necessarily dictating care, but at the same time, that's also probably the correct answer. I don't need an MRI on your knee to start working on making your leg biomechanics work better such that there's less stress on that knee. And there's one of two things that's going to happen. Either it's going to get better or it's not. And if it gets better, then do we need to take a picture of that knee? I don't think so. Because what are we doing if we take a picture? Then we're focusing on that tissue and lesion, that painful structure. And then people start wanting to do things to that painful structure as opposed to focus on why is that structure painful in the first place.
I'm so glad you explained that. I am. Because you often hear, oh, we need an MRI. People are saying, well, why don't they get an MRI first? Why don't they get an MRI first?
I go the other way and I say, listen, there's so many practitioners who are just short circuiting their detailed history and biomechanical assessment that they just think, okay, well, you have this shoulder pain. Let's just get an MRI and we'll just see what's going on. That doesn't really tell us what's necessarily going on. We need to do an actual exam of this person to see how are they moving? How is their strength? What loads can they tolerate? Because just because it shows up on an MRI doesn't mean it's the painful thing. I get that all the time as well, where someone has an MRI that shows X, Y, or Z, but then they come into my office and I start looking at them and I have them move and I have them do different things. And it's obvious that that's not the painful thing in the first place. So they're already going down the wrong path because they're just relying on this picture. Again, if the picture doesn't match the symptoms, then the picture isn't important. Right? I think it should be more where practitioners are looking at patients, listening to patients, seeing how they move, doing different things to really identify what's going on. And if they decide, okay, this person has a really big rotator cuff tear in their shoulder, right? And we think that this rotator cuff tear is big enough that we're going to need to do surgery on it. Okay, that's absolutely fair enough. I'm not necessarily anti-surgery at all, but there's a time and a place. If you get the neck moving and you get the upper back moving and you get your shoulder blade moving and the collarbone moving, everything around the shoulder moving, and that rotator cuff doesn't calm down and it's still very, very weak, then maybe you want to have a surgery. So I think it should be, you're thinking to yourself, I think I need surgery on this shoulder. I'm going to get an MRI to confirm the diagnosis that I already have, which is a rotator cuff tear. If the picture confirms the diagnosis that I already have, then it makes sense to go in there and do that rotator cuff surgery, and do it that way, right? As opposed to the other way around.
I'm glad you explained that because, as you know, there's several people out there right now who are in pain. And I think deep down we want a quick fix, but we can't do a quick fix. That's one thing we can't do. And I'm glad you're explaining that. There's a process.
And I'll go one further.
Yeah.
If you need that rotator cuff surgery, right? If you've torn your rotator cuff and you choose to not do physical therapy first, you probably have a neck that's really stiff. You probably have an upper back that's really stiff, a shoulder blade that doesn't move very well. And if you have that surgery, you come out of that surgery and none of those places move very well at all. So then post-surgically, we have to both move that shoulder that has had the surgery on it, but then we have to try to figure out how are we going to get the neck and the upper back and the shoulder blade moving in the presence of that brand new surgery.
Wow.
Right? Because if you don't fix the reason why that rotator cuff became a problem in the first place, it's going to become a problem in the future.
Exacerbating what actually probably needed to be taken care of first.
Yes. Or if you have a neck problem, right? Say the normal C5, 6, C6, 7 degeneration that we all have if we're not 20 years old.
Right.
And you start getting some symptoms into your arm and you start getting some radicular symptoms, meaning you have a little bit of a nerve compression and whatnot. And they say, okay, well, we need to fuse this segment. It's like, okay, I'm not necessarily saying you don't need that surgery to fuse that segment. But if you don't get the segments below and above doing what they're supposed to do, guess what happens if you fuse that segment? You just created a problem above that fusion.
Yeah.
And below that fusion.
Yeah.
Because if you take out the one that's getting beaten up, your brain doesn't care that the rest of them aren't moving well. It'll just beat up the next one in line. And that's why you see people who they had their fusion and then 3 years later, oh, I got to have a fusion of the one below that one. Oh, and then 3 years later, oh, I got to have the fusion of the one above that one.
You really are explaining it. I'm glad you are. So you have elaborated on some of the misconceptions about pain management. Do you use different approaches to help explain to patients the process?
Obviously, the beauty of physical therapy is I get to see people 1 to 2 times a week for anywhere from 4 to 6 weeks. So I don't have to give them all of the information in a fire hose on day one. We just need to figure some things out about what's going on with them. We need to figure out a direction that we're going to go, and we need to get them on board with the idea of movement is going to be the answer. After that, then we can talk about biomechanics for the next 6 weeks, and we can talk about why we're doing what we're doing for the next 6 weeks and why maintaining normalized movement is going to be how you stay out of my office and how you stay out of the surgeon's office for a much longer time.
What would you advise someone who gets information stating that, hey, I really want you to go? Because, some people are very apprehensive.
Yeah.
They are. And I don't understand the full deal. And you may know more than I would why they're apprehensive. But what would you give them as an encouragement if they are told to go to physical therapy? What would you want them to walk in the door with? I'm talking about mind and physical.
What you're identifying is a very common problem. I think my cancel rate for new patients is much, much higher than my cancel rate for established patients. They get a physical therapy referral and they sign up for physical therapy. And then they're like, I don't know, I'm not going. And then they just never show up.
Right.
And I think part of the problem is that their idea of physical therapy is they're going to make me lift a bunch of stuff that's going to make this thing feel worse. And all it's going to do is exacerbate this problem. Because every time I move it, it hurts. And every time I do something with it, it hurts. So if they are going to make me do a bunch of exercises to strengthen this arm, then it's just going to make it worse.
Yeah.
And I guess what I would say to that is, because we are going to be looking deeper into the root of the problem, we may not be asking you to move that painful thing. We may be moving other things around that painful thing to take stress off of that painful thing in a way that should decrease your pain. Now, I will say physical therapy is not going to be a pain-free process, but that's kind of life as well. And the idea that you can fix musculoskeletal pain without any pain at all is also just kind of a fairy tale. People kind of want to resolve things without any effects that they don't want. I don't know what to say about that. Besides, that's not realistic. That's not how it works.
Yeah. That's the reason why I brought it up. So many people have that fear,
Mm-hmm.
I don't want to go because I don't want to hurt.
Yeah.
Well, they're not there to hurt you. A physical therapist's intention is not to hurt you. They want to find out where it's coming from, what's happening, and how they can make you feel better. And if it doesn't work, that's the purpose, to have it on file so they can go to the next step.
The question of did it work is also a little bit of a misnomer as well. I mean, I get people who come in sometime for 1 or 2 visits and they're like, okay, well, physical therapy didn't work. It's like, well, okay, there's a lot wrong with what you're thinking there, because you didn't do your exercises at home. We didn't get very far in the process, and you're only looking at this from a pain-centered standpoint. If you look at this process as a graph that, instead of having one line of good to bad, it has multiple different lines. And some of those lines are going to go up and some of them are going to go down at different times. Your range of motion might be getting way better, but your pain hasn't moved at all. Maybe your pain is much better, but your function, maybe you haven't been doing anything. So, okay, well, great. If you don't do anything, you don't have any pain. That doesn't sound like life. So if we think about a multifactorial graph and we think about over time, all of these things ending up where we want them to be, but getting there at different times, that's what success looks like in physical therapy, especially when you're talking about, someone who's had a pretty major knee injury. A lot of times they come in, they're very, very painful, and their range of motion is really, really terrible, and their function is really, really terrible. They might get better very, very quickly in terms of range of motion, but their pain level hasn't changed at all, because you start doing some gentle motion, that knee responds really, really nicely, or they have the ability to weight bear, 5-6 days later. Okay, now you can walk a little bit. You went from not being able to walk at all to being able to walk 5 minutes. That's a huge change, but your pain didn't get any better, but that's still improvement. So I just think that if people stop focusing so much on pain, which I know is weird because that's sort of why they're in the office in the first place, and they start looking at the whole system and say, I need to be moving better, I need to be stronger, I need my function to be bigger, and I need my pain to be better. That's when we start making a lot better gains with people, when they can start looking at it from a more holistic fashion.
Oh, I love it. Okay. And the reason I'm going so deep is because I just hear a lot of people talk about pain, 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 pain.
Mm-hmm.
And nothing against what's happening. Trust me, pain is pain. Trust me. But physical therapy is so important. And that's the reason why I started off asking, hey, I just saw this, like you said, it's almost like a PCP for physical therapy, just making sure that we're meeting the needs.
One other thing, I know this is going a little bit different here. I've been talking about this as a totally musculoskeletal, mechanical issue as well. Right. And it turns out the brain is attached to the body and the body is attached to the brain. So we need to be really looking at the biopsychosocial aspects of what pain is as well, right? Pain is an experience that your brain is interpreting all of the input that it is getting into it, right? And so pain is an experience that is different for everyone, and different people feel pain in different ways, and your experience and a whole host of different aspects can change pain science. Believe me, that's two other podcasts down the road. But I also would just kind of want to acknowledge that pain is not a light bulb that is attached to a wire with a switch on the end. It's not just a turn it on, turn it off kind of thing. There's a lot of interesting neuroscience that needs to be discussed.
Excellent, excellent. That's the reason why we have you here. This is a hot topic that a lot of people don't want to talk about. And I felt that it would be great to have you, David, here to talk about it. Because I just kept reading your stuff. I'm like, he really is holistic with the patient. He's very patient centered. And I said, what better person than to bring you on? You emphasize personalized care and understanding each patient's unique narrative. You've been doing that. And how do you ensure that your treatment plans are tailored to individual needs while still incorporating evidence-based practices? We talked about that part. What about the evidence-based practices part of it?
Physical therapy. There's nothing worse in research than physical therapy research. We are probably the worst at it, in the sense that our ability to produce research that demonstrates that our treatment is effective is absolutely terrible. And part of the reason why is because I think that research is incredibly challenging to do. So imagine the simplest study I can think of, which is, will this drug decrease systolic blood pressure by 20 points if you take this medication once a day for a month? Yeah. And you think about how much trouble and expense pharmaceutical companies have doing that kind of study. Then we extrapolate that to, okay, you have low back pain. How are you going to do a study on low back pain? Are you going to find 1,000 people who have the exact same low back pain, the exact same functional movement problem, the exact same joint? You can't create a group of people that have the same exact problem. That's number one. Therefore, physical therapy, if they don't have the exact same problem, probably shouldn't be treating them exactly the same way. So I can't prescribe to you, okay, do this joint mobilization to this person on this day in this exact same way, and do it to 500 of them, but don't do it to the other 500 of them and see what happens, right? You have to identify what's going on with each person, how they're moving, how they're not moving, how they're strong, how they're not strong, and all the other factors that we're looking at, and then work with them in an individualized way, which is not how research works. I mean, at best, we can do case studies, which are terrible in terms of really providing evidence of what works. So what happened was, probably 10, 15 years ago, the pain science folks, who actually can do a pretty good job of creating studies, demonstrated that pain science can be an effective way to change people's pain. It legitimately is a really great place to start. But then people took from that and was like, okay, well, we can prove that pain science works, so we should do this because it's evidence-based. But manual therapy, we can't prove that it works or does anything. You can't prove that you can identify a joint that doesn't move. You can't prove that you can get that joint moving, even if you could identify it. You can't prove that that is going to change the person's pain or dysfunction if you can identify it and move it and all of those different things, right? So when I get to the idea of evidence-based practice, we kind of have to go back a little bit to some more basic ideas about biomechanics. We have to go back to some more basic concepts of what practitioners have been doing for a really, really long time that has been effective. But then you get into all this guru kind of stuff where you have, these groups that, okay, we do physical therapy this way and it only should be done this way because X, Y, or Z. And this is the answer to all of the problems. And when you really dig into it, there's so much overlap between techniques and ideas and whatnot. It's a challenge.
Okay, I got you. It's a challenge because no one person is the same.
Yeah.
And I got you. I really do have you on that. Like you said, the pain science, you've intrigued me. I would love to learn more about that, but not today. Maybe we can come back and talk about that because that sounds very intriguing because you seem like you really like that part too.
Well, oh man. I mean, when you start talking about what goes on from the brain in terms of how the brain is interpreting pain and then what's going on hormonally in terms of things like oxytocin and vasopressin and cortisol, and how your nervous system can either be ramped up or calmed down with different techniques, and how your pain experience can change dramatically. It's very interesting. And just the idea, if you can tell people, if you can let people know on day one that pain is not damage, and just that idea, that concept, like pain is not damage, that can change a whole host of different attitudes with people.
Wow. Oh, I like that. David Jetter, we've hit our time, but I want to say thank you.
Yeah.
You have given a host of information talking about the musculoskeletal system, talking about the biomechanics of who we are and how our bodies move, understanding that physical therapy is not something to run from. It is something to run to. Just because the pain is in one place does not necessarily mean that's where the actual problem is. And then we talked a little bit about research and how it can be a little, muddy water at moments. But you have offered a lot of information that I'm hoping that the followers can take, especially those who may be skeptical of physical therapy. It's not something to run from. I want them to know that ask the questions, use this opportunity to ask questions to your physical therapist. What can I expect? What can I hopefully gain from it? And yes, sometimes you can't fix it. Our ultimate goal is to find out how can we ease the pain in some manner, or where can we take it for its next step. I really thank you for this. I really do. It was very informative.
Yeah, it's a lot of fun. And honestly, if you want to go down another rabbit hole beyond pain science, we start talking about neurologic stuff. We start talking about Parkinson's disease. We start talking about, older folks with balance problems, and taking them from relatively poor balance to as good as they can be, knowing that over time, you're always going to be on the decline as you get older. But increasing your ability to move correctly and be strong and have good balance in, say, the fifth and sixth decade of your life can pay off dividends in the eighth decade of your life.
Oh, see, now you're going to have me call you back.
That's a teaser.
I know you did. Okay, y'all heard that. We got a teaser. I'm going to have to, because I love the neuroscience part. Okay. Well, I want to thank everyone for coming on to Cold Press Conversations with David Jetter. And if they want to get in touch with you, what's the best way?
I think one of the most interesting things you can look up is on Facebook. I have a little group called Start with PT. And it just kind of describes a little bit about where my thought process is with physical therapy, and why starting with physical therapy is probably the right answer, unless you have an emergent problem, right? I mean, if you have bones sticking out of your arm, then do not come to PT, right? If you have chest pain that's going down your arm and it's hard to breathe, you should not come to PT, right? But if you have a problem that's been going on for a while, or even a relatively new injury, starting with physical therapy is really probably your best choice, because hopefully we can resolve the problem. And if we can't resolve the problem, we're going to make you a much better surgical candidate.
Oh, excellent. I can't leave you without saying this one thing. If you were to get a cold press juice, what would you get?
I like the spinach, kale, banana, strawberry.
Do you really? Okay.
Yeah.
Well, thank you so much for joining me, David.
Well, thanks for having me.
I hope you enjoyed this episode of Cold Press Conversations. If you love this episode as much as I did, I need you to head on over and subscribe so you never miss an episode. This is Dr. Jewel signing off to health and cognitive happiness.